We all recognize these tiny Ziploc bags. They're often attached to a new sweater or jacket and contain an extra button. Well, they're also the bags heroin comes in. It seems there's an explosion of button distribution in the United States. Gina Colada, writing for the New York Times, recently said drug overdoses are driving up the death rate of young white adults ages 25 to 34 in the United States to levels not seen since the end of the AIDS epidemic more than 2 decades ago. Current thinking strongly recommends treatment of addiction with MAT, or medication-assisted treatment. But according to the Pew Charitable Trust, while 900,000 doctors across the U.S. are licensed to write prescriptions for opioid painkillers, only 32,000 are allowed to prescribe Suboxone, one of the most successful medications available to treat addiction. In her February 15, 2016 article in the New York Times, Tina Rosenberg writes that trying to kick opioid addiction without medicines is as smart as relying on willpower to overcome diabetes or asthma. My guests today are Dr. David Novick, a gastroenterologist who provides opioid addiction treatment, and attorney Jane Novick, who specializes in special ed law, juvenile law, elder law, and estate planning. The Novicks live and work in Dayton, Ohio. I'm Alice Bloom. This is A Town and Village 2. Welcome back. David, Jane, thanks so much for being my guest today. Now, I was inspired to invite you by an article that you co-authored for the Bar Association in Ohio, an article stressing the need for medication-assisted treatment. Is that correct?
Yes. Yeah. We wrote the article because the same magazine had a previous article on the heroin epidemic, and they didn't mention treatment. And treatment is just so important and not really always implemented. And we need to publicize much more that there is effective treatment available.
Well, I've learned how complicated this issue is, but let's start at the beginning. What do you think is the reason for the tremendous increase in heroin addiction in this country?
Well, when I was in medical school, we were taught to prescribe opioids only for cancer or end-of-life issues, and really not for chronic pain conditions such as arthritis.
Okay, opioids are the strongest painkillers.
Are narcotic painkillers. Examples are Vicodin, Percocet, OxyContin. And so it's only maybe in the last 20 to 30 years that the principles changed, and doctors started thinking that pain is a vital sign and always has to be treated. And I think there was a lot of overprescribing of opioid painkillers, and we see that there's millions of people in the United States that use them for non-medical reasons. Estimated 1.9 million are dependent on opioid painkillers.
So what you're saying is someone is prescribed Vicodin or OxyContin because they've had some legitimate pain, but then they're addicted. Why do they not stay on the prescription pain medication? Why do they transfer to heroin?
Oh, well, one of the reasons for that is that the prescription drugs have become more expensive because they have started to rein in doctors, and they're watching them how much they're prescribing these meds. So the drug dealers, being the good business people that they are, have made one capsule of heroin, for example, as cheap as sometimes 25 cents, realizing that once they get them, their tolerance keeps upping, and they're going to need more and more, and hence they're soon going to be spending, hundreds of dollars a day sometimes. But initially, that is a much cheaper alternative than someone who is on prescription opioids and now can't get them, or they become too expensive.
So we're taking somebody who was ill or had surgery, had some legitimate need for pain medication, and gets hooked, and finds the only way to tolerate living is to then use heroin because they can't afford the medication or their doctors won't prescribe anymore. So now they're on heroin and they're in the drug world. Somehow this has morphed into our suburbs and rural areas, more so than the cities.
Yeah, we have an epidemic now of heroin addiction, and it's in rural areas. You don't have to go downtown to the inner city to buy heroin anymore. The network is everywhere. And it's affected women to a much greater extent. It's affecting young adults, and it's more of a white epidemic, which may explain a little bit of why it may be getting more attention, but it's not getting enough attention.
It's not getting enough attention, but let's just stop there for a second, because what I have heard, and I think that something that you embrace, is that this has been a problem in the communities of color for some time, but largely treated criminally. And now we're seeing it invading the white community. And now it's being revealed as an addictive problem and a health problem, a public health problem.
It's always been an issue that cuts across all lines. It's never been restricted to one particular group, but it is true that people thought of it as more of an African American problem, but that's really not accurate at all. Not to say that they're not affected, but certainly the statistics on the recent epidemic show much more white, rural, and women, rural or suburban, and that is a change from before.
Now, there are legal issues involved in this. Prior to this, it was treated as a criminal drug. We have drug courts. We have people who are incarcerated, and 3 strikes you're out in New York, and because they were addicted. But we now know it's a public health issue. Jane, of course, that's your bailiwick. I mean, address it from the legal standpoint.
Well, actually, as early as 1986, Rikers Island started a program where people that were incarcerated for 1 year or less who were heroin users, which was more that than the prescription drug problem, would be given, at that time they used methadone. Suboxone was not used as widely. They now do Suboxone. They would be treated with that, and they were also given counseling. In addition, Mayor Bloomberg realized that that's not enough. You have to also deal with the poverty issues. So help was given as far as making sure housing was going to be there upon release. Also help to get a GED, high school diploma, or something more advanced. All of those issues were dealt with. And then shortly before release, they would connect that person with a community-based drug program. So upon release, they were automatically in a medication-assisted treatment program, and they didn't have to think about it. And it was widely successful. We now see that in quite a few other states. Not enough states. And actually, the biggest problem is that many times when someone is initially incarcerated who is a heroin user, they're forced to go cold turkey. That actually leads to death sometimes. And if not death, it is, if you've ever experienced watching someone, it is horrible. And there have been talk about this being a violation of the Constitution as a cruel and unusual punishment. And also for people who are on MAT, who are forced off of it, that it's a violation possibly of the ADA in that they are not being given a reasonable accommodation. And that is still more the norm.
Now, one thing that you told me, and I think it's very important, is that addiction is not a voluntary behavior, and that, in fact, people who become addicted have real physiological changes in their brains and bodies. Is that correct?
That is correct. Addiction should be thought of as a brain disease. And if it goes on for more than a few months, it's likely to have some permanent changes. And research has shown that such people will do much better if they are treated. And the treatments involve long-term, long-acting opioids. These are opioid drugs, methadone and buprenorphine. The brand name is Suboxone. And these drugs have a greater than 24-hour half-life. So they stay in the body and they develop a very stable blood level. And the patients, instead of having opioid withdrawal, they tend to feel normal. And of course, it takes time to get the right dose and for the patient to get used to it, but people who have opioid dependence don't get high from these medications. They more or less feel normal.
But what do you say to people who say, well, you're substituting one drug for another? Why is that better?
Well, because the pharmacology is very different. The long-acting opioids, as already mentioned, they level out the patient, they prevent withdrawal, they prevent craving, and they're given orally, so you don't have the risk of infectious diseases such as hepatitis C and HIV infection, the causative agent of AIDS, which can be transmitted by needles, not to mention many other medical conditions. So it's safer, it's in the public interest. Even if that were the only difference, it would be in the public interest to have heroin users on an oral drug that keeps them more stable and more normal. But the drug is considered treatment. Methadone or Suboxone is considered treatment, not addiction. And it does have to be combined with counseling to be effective. But it should not be considered as, even though it is a drug that is physiologically causes dependence, it's considered treatment.
Jane, you compared Suboxone to other medications that are used.
Well, two things. One thing that you briefly brought up in your opening segment about an insulin user, diabetic. We never tell a diabetic, okay, when you're going to come off of insulin. Because the pancreas is chronically not working properly, we expect someone's going to need that, generally speaking, forever. The same thing, as David said, this is a brain disease, a heroin, an opioid addiction, and they're going to need this treatment. And unfortunately, a lot of times we see the opioid abusers and many of the treatment centers who see this as a short-term and not a long-term treatment, and that's incorrect. Now, I know there have been times that David has had people successfully come off, but from what he's explained to me, that's more the exception than the rule. That's a problem. And again, the other issue is that there is a positive use for OxyContin, for Vicodin, for Percocet. We don't consider when somebody takes it legitimately in an appropriate manner that they're an opioid abuser. The same thing with Suboxone. When it's used appropriately, it's not being abused, and you're not considered an opioid abuser because you're taking Suboxone. And unfortunately, that stigma that you take it at all, they think that, well, you're still an opioid abuser, is incorrect, because there is a correct use for these medications.
Okay. So if I'm understanding correctly, it's not a legitimate expectation that most people could ever be freed of all medication.
I don't know if I'd want to say ever, but what is really the goal? The goal is recovery. And recovery means getting integrated into society, avoiding the medical complications of heroin addiction, solving their multiple legal, economic, and social problems, and often mental health problems that go along with it. Recovery is a very global kind of thing that has a lot of aspects to it, and really getting off of an opioid treatment should be the last consideration. I'm much more interested in someone functioning normal. I'd like to see someone working. I'd like to see someone getting counseling for their social and mental health problems. I'd like to see someone paying taxes, not committing crimes. And those are my goals. And I think that's what most people, if you had someone in your family that had an addiction problem, that's what you would want or should want. But too many people never even try such treatment.
Are there any studies of the long-term effect of being on withdrawal treatment drugs, Suboxone or methadone?
I personally did such a study with methadone, published in 1993 in the journal Drug and Alcohol Dependence. And we looked at people who were on methadone for 11 to 15 years, and we found no significant health problems. Amazingly, opioid drugs generally don't cause tissue damage. They cause biochemical changes in the brain, and they bring along infections with them usually because of unclean needles that the patients use. But they don't have toxicity in the way that many other drugs. They don't cause liver injury or kidney injury. These drugs are, in that sense, remarkably safe. It's just that once you've been on them for several months or longer, it's very hard to get off of them.
Okay, but you're saying if you maintain those maintenance doses under a doctor's supervision, that you should be fine for the long term.
That's correct.
Are there any downsides? What happens to a person who falters, who might try an opioid again?
I think we have to understand that addiction is a chronic relapsing disease, and it's not like treating pneumonia with penicillin. You're going to have relapses, you're going to have slips. Again, people who are dependent on opioids, who've used them for a long time, generally have a high degree of tolerance, and even if they take extra, it usually won't harm them too much. If you or I did so, it would. If you take enough, of course, you can overdose.
You could overdose. What happens to someone who actually goes back to heroin again?
Well, they run the same risks of infections, and
would their tolerance for the heroin be the same, or would they?
Well, one of the problems with heroin is you're buying it on the street. You never know what you're getting. You don't know what your friendly drug dealer is putting in it. There have been a lot of cases recently where they mixed fentanyl, which is a narcotic, but it's an anesthetic type of drug, and they mixed it with the heroin, and a lot of people died from that. Not good business for the drug dealers, but it just goes to show that it's very dangerous. And and I also want to mention, there have been studies on the effectiveness of both methadone maintenance treatment and buprenorphine maintenance treatment, and the studies show that they're very effective. When you compare the retention in treatment to a control group, it's remarkably better on the medication-assisted treatment patients. They stay in treatment, and then they have a chance to get the counseling. So there's a lot of scientific evidence that these treatments work. They've been endorsed by the World Health Organization and the Institute of Medicine in the United States, the Center for Disease Control, and there's a whole website from SAMHSA, the part of Health and Human Services that deals with addiction, that has a lot of information on these treatments.
Okay. I think you also have to realize this is not like when we're in school trying to get 100%. You have to change your expectations. And some of the studies have, retention and recovery at 40%. But you compare that with the abstinence base, which are generally less than 10%. So again, what's successful is very different from what one might consider that, as I said, in our normal life when we're in school, or what our expectations were in doing well in work and whatever. So I think that's one thing that we have to keep in mind.
So if medical treatment really does seem to help, we understand nothing's 100%, just like weight loss programs, nothing's 100%, people lapse, we're all failures in some ways. If treatment centers with counseling help, why are there not enough treatment centers?
I think part of it is financial, and part of it is a stigma associated with the patients and with the treatment. Certainly, if there were better reimbursement for some of these services, you would probably have more physicians interested in treating them. Also, people don't like the patients. They have a negative attitude toward the patients. They don't want those patients in their waiting room. The truth is they're seeing them anyway, but and they just don't want to be involved in it. They don't feel comfortable, and they may not really know that much about the treatment. But the Drug Abuse Act of 2000, which authorized physicians to prescribe buprenorphine for the treatment of
Suboxone.
That's Suboxone, okay. In their office for the treatment of addiction. Physicians have to take an 8-hour course, and request permission from the government to prescribe it, but it's not a real problem.
Now, they don't need permission to prescribe opioids.
No, but to prescribe it for the maintenance treatment of addiction, you do need a waiver.
Does that make sense to you?
Well, there are laws against over-prescribing. So, and back in the early part of the 20th century, they made maintenance treatment illegal. So now they have to put in waivers for that, to allow that type of treatment.
I'm having trouble wrapping my head around it. It just seems wrong that someone could prescribe opioids, maybe in good faith, but without any follow-up on how that person is doing or how much they're using, and yet they can't prescribe the maintenance drug that will help them.
Well, we certainly need more people prescribing it. We need the medical profession to step up a little and get more involved, because it's a major public health problem of our time right now.
And actually, it's only with the Affordable Care Act that a lot of insurance companies now will pay for substance abuse treatment. That was not the case before that. That was specifically added into
So
that.
this is only the last 2 years.
Yes, so that is one thing. Of course, a lot of physicians who do this sort of treatment do cash only because it's far more remunerative, and I think that's what's going to bring it in. But of course, a lot of these individuals can't afford a cash only place and rely on various forms of Medicaid, or if they happen to have private insurance, or they're under their parents' private insurance.
Now, how expensive are these drugs?
I don't have that at the tip of my tongue, but they're not exorbitant. Compared to many drugs available today, they're reasonably priced.
Okay, well, let's talk about a drug that is pretty exorbitant, Vivitrol. I've read about this. It's not yet available.
Oh, it is on the market. It is
Okay.
available. It is a different type of drug. It's an antagonist. It blocks narcotics, but it doesn't bind with the receptors in any positive way. So to me, there's a question whether it will really block the craving for opioids. It's pretty new. The only studies were done in Russia, and I'm not convinced that the evidence is good enough for it to be used in most patients.
Well, let's
I have
talk about,
prescribed it.
But let's talk about what's different about this. Formerly, previous drugs, a patient needed to take a daily pill.
Right.
Vivitrol is an injection, so we're going back to needles, but it's once a month.
Well, it's given in a doctor's office.
Okay,
And
so
yeah,
it
the
do-
once a month is definitely a good feature of it, because I think the patient knows it's in the body for a month, and hopefully that changes some of their conditioned response to the desire for opioids. But again, I think it has potential. I think it needs more study. I personally recommend it for people who've had a relatively short period of addiction where they may not have the full-blown changes of addiction and the brain changes that more long-term addicts have. And that's how I'm using it right now.
Now, it's expensive.
It is expensive. Again, at least private insurances cover it. I don't know for sure about Medicaid, whether they cover it. But it is being marketed very heavily, and it's being pushed in the criminal justice system, where it becomes a condition of probation. And so when you have a hammer over someone's head, it might be easier to take it. But what we will really need is studies on what happens when people leave probation and are no longer being given this drug. And there's actually concern that it might lower the tolerance a lot, and people might overdose if they go back to opioids, because what used to be their normal dose is now too much for them.
I see.
That did happen with the pill form of the Vivitrol called naltrexone. That has been reported.
Okay, you're absolutely right. As I look at my notes, I see that 16,000 people are on Vivitrol now, but there are 1 million people on methadone.
Right. I mean, it's It's just coming in. Look, it would be great to have a whole menu of treatments and to individualize medical treatment. I mean, in general, that's where medicine is going. They call it personalized medicine. We want to have the best treatment for each individual. So if we had a whole list of treatments, and that could be one of them, it may have a role. It's just being pushed and marketed very intensively for everyone, and I don't feel that that's appropriate at this time.
Okay, well, it's an expensive drug, and I guess if it's going to be reimbursed, I think it's about $1,000 a month.
That's right.
Right.
That's
So
right.
it's pretty steep.
What's a little frustrating is we're seeing almost before it was heavily relying on abstinence-based treatment to now going to Vivitrol versus realizing a one-size-fits-all is really not the way to go, that we need to have these myriad of treatment programs and pick out which is the most appropriate one. And which actually leads to another interesting discussion we've had when somebody is brought to court for use of opioids, and rather than just looking upon them as a criminal, we want to realize this is someone with an illness, that they have a disease. And so many times they're being just put, the judges are deciding what type of treatment they're going to get. It's really a medical issue. So should the judges or the attorneys be deciding what type of MAT or abstinence-based program they should go to versus having somebody who is a healthcare provider who is knowledgeable in this area making the decision and treating this as a person with an illness and not just somebody who's broken the law.
I want to give you a question from really left field, and then I'd like, in the minute we have left, talk about the CDC's recommendations just issued today. But we're talking about addiction to drugs here, to heroin. Would the same strategies work for other addictions? Addictions to gambling, to food, to sex, the other kinds of addictions that we hear about in our communities?
Well, if we had a medication or a treatment that was proven effective, but unfortunately for most other addictions, we don't have such a thing. There are a couple of medications that help somewhat for alcoholism. There's really nothing for cocaine or for Valium or other benzodiazepine dependence. And I just want to mention very quickly that the whole abstinence-based treatment has been very disappointing. And those programs don't really keep records of patients once they leave the program. People say they've been to rehab, but the rehabs never publish their data. And when they're control groups of the MAT drugs, they do very poorly. So I think we have to keep that in mind, that a lot of the abstinence-based rehab programs are just not as effective as we wish they were.
I understand. We have only a second left. The CDC issued some recommendations today. What were they?
Well, the doctors have to be much more careful about prescribing prescription painkillers, that they should use them for much shorter durations in lower doses. They should change the patient's expectations that they're not going to be getting these drugs for a long period of time, and that they're not really appropriate for non-cancer or non-end-of-life situations, at least on a chronic basis.
Well, let's hope it leads to fewer addictions.
That would
Jane,
be great.
David, thank you so much for being my guest. I've learned a lot, and I think our viewers have as well. I wish you luck with your work, and I hope that the addiction problem does start to abate. Thanks again for being my guest, and thanks at home for watching. I'm Alice Bloom. We'll see you next time.